Good afternoon, good morning. My name is Paola Hernandez, and I'm Food Project Officer at Healthcare Without Harm Europe. I would like to welcome all of you in this webinar about food waste in the European healthcare sector, where we will inform you about the multiple challenges and opportunities to prevent and reduce food waste in healthcare. And we will explore some strategies that have been already implemented in Ireland and Denmark. We really hope to inspire you. Please don't hesitate to use the chat box to ask any question you might have during the presentations. We will take them at the end of the webinar. Also, just a quick reminder, this session will be recorded and will be available in our website next week. So firstly, we will start with Aileen O'Leary. She's a researcher at the Cork Institute of Technology. She will present the Green Healthcare Program they have conducted in Ireland in collaboration with the Environmental Protection Agency and over 50% of Irish healthcare facilities. Please, Aileen, the floor is yours.
Thanks very much, Paola. Hello, everybody. Eileen here in Ireland, and as Paola just outlined, the Green Healthcare Programme is funded, originally started by the Environmental Protection Agency, but now co-funded as well by the Irish Health Service, which is the HSE, and in particular the HSE's own National Health Sustainability Office. So it had started in 2009 and has been going now since. We've been looking at all solid waste streams coming out of hospitals, so not just food, but also healthcare risk waste, recycling, general waste, and so on. But my session today is focusing on food waste and what we have found over the years. As Paola mentioned, we have been in about half of the acute hospitals in Ireland, and we also have been in the smaller community type hospitals as well. I suppose why focus on food waste? As is well known, there's about 1/3 of all food that is produced is wasted somewhere along the cycle from farm to consumption. Those are numbers from the FAO. The population of the world is growing. We're over 7 billion of us now, and on the left here on the slide you can see there's nearly 1 billion people undernourished, and then the corollary of that, there's nearly 2 billion people who are overweight and obese. There's pressures on land in terms of climate change, reducing arable land, and also pressures from the point of view of an increase in the Western style diet, which in turn has a larger amount of land use. So this is some of the reasons, I suppose, why we are looking at food waste. In the clinical situation, in the healthcare situation, food waste, it's a clinical problem. If patients aren't eating food, then that's inadequate food intake, and that has implications from a care point of view. And we also look at it when we're dealing with the hospitals from a financial point of view, of course, because food that has been purchased but not eaten obviously is a financial cost to the hospitals as well. Just to give you a little bit of detail on the food serving systems in Irish hospitals, there's two main types of systems. One is plated at the ward, so this is the first one I have here, where the food is sent up in bulk in these gastronorms and then plated out for patients. The second system then is plated centrally in the main kitchen, and this is where each patient fills out a menu. It goes down, their tray is filled, and that goes up to the ward then. And within those two systems, we also have fresh cooking, and we also have cook chill, where somebody where a hospital will cook several days in advance and chill it down. So that's the type of systems we have here. I'd be interested to see what systems there are elsewhere. In terms of the work we did, we went in to do food waste surveys, and we usually would go in for one day and quantify the waste for that day. Now, a day is just a snapshot, so we would also try and match that up with the quantities of food waste that are being generated by the hospitals and, you know, reported by their waste contractors. So when we go in for a one-day survey, we would try and categorize the food waste into different categories. The main categories we would use would be the leftovers on the plate. So you can see an example here, what's left over after the patient is finished with it. We would also look at food that has been prepared but was never served. We call that unserved food. So this never went near a patient but ended up as food waste. So that's one of the another type we look at. And the last two areas would be, one would be untouched food portions. So you can imagine where a patient maybe is being seen by a physician that they don't get a chance to eat their meal, and then the meal comes back having never been touched. So that's another category we use. And then lastly, we would look at things, we call them condiments. So you're talking about anything like sugar, butter, and so on, that's packaged and not used. So they're the areas we try and quantify on the day. And then a bit, just to show you an example of one of the set of results that we would prepare for the hospitals involved. This shows you the kilograms per day, and then scaled up for the year based on the tonnage for the hospital. And I mentioned financial issues there a moment ago, and it's important for hospitals. You know, the reason to do this is for sure to improve the environment, but also money does talk for hospital budgets. So this is an example of a hospital we did last year, and you can see the unserved food is the biggest section, and here we've broken it down into the different meals and where it came from. So you can see the lunchtime and wards, and also the lunch in the canteen were the biggest sources of food waste. So that enables the hospital to go and try and tackle those areas in terms of measures of reduction. So we did this for half the hospitals, as Paula mentioned. So we are able to say for all the different waste streams we do, you can see here there's different ones, different waste streams, but this is, circled in green is food waste. And so we have worked out what is the quantity of food waste generated for every patient who stays overnight. So per patient bed day is the metric that we use, and it's 0.7 kilograms for every inpatient bed day we have found for acute hospitals. So that was the average, so 0.7 for acute and 0.77 for community. And then we've actually seen the lowest as well, down as low as 0.45 kilograms on the acute side of things. So that allows the hospital to see where they stand relative to their peers. Another finding we made as part of our surveys, we measured food waste. We measured food before it was even given out to patients or staff, and so we were able to quantify how much of the food was eaten. And in this case, this is for eaten by patients. So this is the average of all the surveys we did. So it's a staggering figure. I think it's almost just over half is eaten by patients, which by difference, just below half ends up as waste. And that waste divides into two categories. One is plate waste, which is I showed you earlier, and then unserved is the category which is prepared but has never, is either remaining back in the kitchen or is remaining up in a ward kitchen in a gastronome. So there are the average results. Food waste costs. This is the iceberg effect. The cost to dispose of the brown bins. The brown bins to collect food waste was introduced in Ireland in 2008, 2009, and people first started to notice, oh look how much food I waste I'm generating, and it's costing me so many hundreds or thousands of euros per year to get rid of that waste. But behind that, the much bigger cost is the cost associated with buying that food, and then also the cost to cook between fuel and staff. So we had a study in an Irish hospital where we looked at the purchase cost of the food. So we did it over the 3-week menu cycle and looked at what the average cost of the food being dumped was. You see this 30% here. We found that 30% of the brown bins had no value, so things like tea bags, peelings and so on. We found that the rest, then 70%, was food that had value. So it was food that was purchased and was meant to be eaten. And the average cost, we looked at all the costs of food purchase and the weights, and we got the average cost over the 3-week period for that wastage of being just over €2 for every kilogram of food. So that translates roughly for one of these 140-litre brown bins that would be fairly common in hospitals here in Ireland, of about €100 of lost food purchases. So the hospital's probably only paying maybe €8 or €10 for every bin lifted, but they actually are losing a lot more in terms of lost purchases. And translating it into tonnage, because usually a hospital will have data back from their waste contractor, every tonne of food waste would then represent about €1,400 of lost food purchases. This is an example of a recent hospital. We were at a small enough hospital, 240 beds, and they had 27 tonnes of food waste. This was costing them €4,000 a year in their brown bin charges, and they were quite good, really. They were that kg per bed day metric that I showed you. They were actually a good bit below the average, so they were quite good. But even still, using that 70% food having value and €2 per kilogram, there is about €38,000 of food purchases in their food waste every year. Now, you'll never realise all of this savings, and the nature of a healthcare setting is very complex. The patients away at scans, or feeling ill, or trying to work out amounts to send up to the wards and so on. But it allows to put a figure on the cost, and maybe hospitals then can take that and look at reducing it by, say, maybe 5%, 10%, 20%, and work towards making some savings that way. If we scale it up nationally for all Irish hospitals, on the acute side, it's above 7 million in terms of lost purchases, and then on the community hospitals, another 4.4 million in terms of lost purchases. So in terms of good practices that we've observed, I would always say, regardless of the system, I showed you earlier, was it bulk going up to the wards, or was it plated up in the main kitchen? There's always scope, I think, for food waste reduction. And the key thing is communication. Make sure whatever menu system is there works. The prepared food that hasn't been served, there's great potential there, because it's not down to the vagaries of a patient and whether they feel like eating or not. It's stuff that was sent up but not used. Things that different hospitals in Ireland have been doing to try and reduce food waste include things like reducing the meat portion, the plate size, trying to portion out meals that are like lasagna and pasta, where it's not an individual portion, looking at reducing scoop sizes and number of scoops and the associated staff training with that then. Bread and condiments are often just issued automatically on trays. Again, this is an area people try to improve, just to give them out on request. You're always trying to balance off this sort of issuing on request with staff, because people are always under pressure for time. I'm sure it's the same everywhere. A lot of cases where people are trying to under time pressure to get food out across the board, and we've seen that again and again. The biggest source of food waste is always the main meal, and that's where the main savings would be. I think for a hospital, if they haven't really looked at food waste before, the best place to start would be start measuring food waste weights, ideally by ward, and that kind of help you see where the big areas are. Protected meal times do work in some hospitals, but they have to be enforced. Some hospitals find where if they're not enforced, then it can slip, and the medical staff can start coming back in during the meal times. And electronic tablets, there's 1 or 2 hospitals here now in Ireland who are using those, so it would be interesting to see will that help them on their food waste. Just one case study we have of St. Michael's Hospital, which is in Dún Laoghaire in Dublin, and we went in and measured their food waste. They'd made some measures, and we went back and measured again, and they had reduced the food from the wards by 40%, or 12 kg on the day. So they'd done a number of simple things, really. They reduced the amount of porridge that was been sent up to the wards. They looked at different portion sizes for elderly patients. There was plenty of training of staff. They were reusing food from the canteen then that wasn't served in the vending machine, and things like even something small like the amount of milk that's poured into a jug. People tend to fill the jug to match the size, just so reducing the size of the jugs, and always in conjunction with the dietitians as well. So that's what I have to say. I just show you our website at greenhealthcare.ie, and also the National Health Sustainability Office have their website on hsc.ie/sustainability. And here we have some case studies like the one I've just shown you, and some others of Irish hospitals and what they have done, and some guides, fact sheets and best practice guides on food waste and other waste streams. So thank you very much for listening, and hope to hear your questions later on. And I'll hand back now to Paula.
Yes, thank you very much, Eileen, for your great presentation and differentiating between the diverse food waste types, showing us some of your results and bring some data in terms of cost. This is really useful. Yes, thank you. Now I will introduce you to Sister Holub Larsen, clinical dietitian specialist, and Nina Johan Stavek, development consultant at the Gentofte Hospital in Denmark. I'm really pleased they are here today with us as well, as they are particularly willing and active in preventing food waste at its hospital while improving patient satisfaction and investing in more organic food products. So welcome, Cisa and Nina.
Hello. Thank you. Yes, hello, this is Cisa speaking. I'm going to start out telling you about how to lower food waste and use a case study. I'll tell you about Gentofte Hospital. The concept that we are using is that it's the kitchen staff that serves all 3 meals during the day, weekdays, and not in the weekends, because then the nurses need more flexibility. When the kitchen staff goes to the wards, they are calculating how much food to get to the next day. I'll get back to that later when I show you a scheme. When we started this concept up, we used we used to have the round plates, and now we have smaller serving plates. I'll show you later, and it's decorated more appetitely, and the patients think it's easier to get appetite when there's a smaller plate compared to the larger plate. Furthermore, we have a snack cart who runs around in the hospital twice a day for all the patients. They also deliver menus to the patients so they can see what's being served today. I prefer calling it powerful service because it's the patient really appreciates it. Furthermore, these actions were paid by the wards when we introduced the concept. The wards are paying, and in addition, the food waste. When we minimized the food waste, the money we had from that was put into this concept. Before, when we were serving the main courses, it was in bulk and it was not very appetizing. These are nurses serving. And these days you can see how breakfast is served on the left and the lunch on the right and the small plates. And then the patients can choose between whatever they want from the buffet, or they can see at the menu. And this is what it looks for in the evening. As you can see at the first slide, in the first picture here, it's warm. We're serving warm meal for lunch because it's easier to get it fresh up for the patients, and it's easier to serve cold in the evening. Yeah. And this is what the plates look for the patient in when they are being served the menu. This is the menu that the snack cart delivers to all the patients during the day, so they can see what's on the menu, and then they support whatever they need and what they prefer. And sometimes you need to remind yourself that when you are preparing a menu in the kitchen, you have an idea what the meal will look for the patient, and you take these pictures thinking this is what the patient should be offered. But the truth is, when we look at this picture, this is actually what the patients are seeing when they have the meal served from the nurses, some of them. But that's one of the main reasons why we wanted to introduce kitchen staff to serve the course. This is a snack cart. You can see the 2 lovely girls that goes with their cart every day. And the snack card there's 2 of them at the hospital. There is about 260 patients in the hospital. They have 2 routes. There are 2 persons. One of them is a bachelor of nutrition, the other one is a dietitian, just to make sure that if the patients have any questions, they can be answered. And furthermore, we also offer these snacks for relatives, so they can be a social part of the hospital. And this is what is served during before lunch, and the other one is what's being served for afternoon. And as you can see, there is these glasses with the milk, dairy, protein supplements. It's homemade, and 1 glass of it is with about 1,000 kilojoules, approximately 240 calories, and 10 grams of protein in each glass. We have learned from the snack card implementing it that there's a need for high professionalism among the staff serving. They need to know the language and the tone and the process in a clinical department. They need to be aware what to do if the patient is in isolation. Many of the patients ask for diabetes-friendly snacks. Maybe it's not the nutritional correct thing to do, but that's what they prefer. We learned that the relatives have a very big influence on what the patient wants. And we need to include all the staff in the kitchen and on the wards to go into this project. And the patients loved it, that's what we learned. According to food waste, when the kitchen staff goes to the wards, they have this registration scheme where they where they put down the figures of how much food they had up to the ward, how much they had served for the patient, how much they had with them back. And the menu for the next day is there too, so they can order it. So if they can see, oh, today there's only 10 patients at the ward, the nurses say, oh, tomorrow there'll be 2 more, so they only ordered the amount that they're expecting of patients. And this shows the food waste. This is what we use the schemes and the figures for from the previous scheme, how much food waste from the wards. And you can see at breakfast there is quite a lot of food waste, and it goes better during the day. One of the things we think that the reason is that for breakfast there's quite a lot of different alternatives of bread, different kinds of breads that you can choose between. So there needs to be a wider range, yeah, because one day you want some bread and the other day you want something different. But these are the figures that we can work from, and then see if there's anything we can change, and then additional, we have these boxes that collect all the leftovers from the wards. So all the food that wasn't served to the patient is put down here, and then it goes into this EU tank, where we pour the food waste in the mill. We have 2, one on the first floor for production and one in the basement for food waste, which is set to be returned from the wards. The food is ground with water collected in 2 large tanks in the basement. About every 3 weeks, the food waste is collected and sent to gasification, and after completing the biogas, it is used as a fertilizer and sprinkled onto the fields. It should be rich in phosphate, which the soil is missing. Yeah, and Nina?
Yeah, this is just a short slide about how in the kitchen how we use some of the leftovers. When we make our small rye bread for dinner with the different eggs on or ham, then we have many ends left. So with the ends of the eggs, we mix together with, for example, mayonnaise, and then make this egg salad, which we put on the rye bread the next day. And we use a lot of herbs to give a good flavor to our food. And many of the stalks in the past we didn't use them, but they actually have a very good taste of the herb and have a good crunch, so a good texture. So we also mix it into this egg salad. Oh, sorry, I thought I was pointing with the with the arrow. I do now. So the stalks of different herbs is mixed with this egg salad, and then it gives the egg salad more crunch instead of just being like very soft. The ends of the rye bread we mix together, make into this Danish typical breakfast porridge made from rye bread, old rye bread actually. And early on we used to buy frozen blended, how you say, mixed up rye bread that was non-organic, and now we can use our own organic rye bread ends, which is organic and the same price. So that's very nice. The ends of ham we also mix into the salad with the mayonnaise and also put on as a spread on the rye bread the following day or so. So that's kind of, it's all often the ends that we need to find a use for. But with the white bread right now we also make into like these small breadcrumbs and then make actually a cake, nearly 100% a half at least, instead of using pure flour. We use half flour and half mixed with the breadcrumbs.
So in the future, we want to have focus on increasing the professionalism for the meal hosts, so they feel comfortable of what they're doing and have the knowledge to increase the intake. We want to continue developing the concept. We want to provide money for more organic food, which Nina will tell you more about in a few seconds. And we'll have a look at the cooking methods and how to reduce the use of plastic. Yep.
Hello, this is Nina again. I'll just tell you a little bit about our organic food here in the kitchen or at the hospital. Right now we have this very nice percentage of 80% organic food, and we are actually within the budget that we had before. And how come? We're gonna learn now. First, you need to think about conversion versus restructuring, which is maybe not the best word to use, but it's a kind of Danish translated. Conversion is where you only change that the products are organic, so you use the same kind of products and you have the same kind of recipes. So before you bought everything conventional, and now you buy everything organic, and that's very expensive because organic products do cost more. Restructuring is also rethink your way of cooking. And how do you do that? First, on average, you should not spend more than about €3 per kilo. After you always have to look at like how many kilos you buy in total per month, and then divide it by how much money you spend, and then it shouldn't be more than these €3. That's a good estimate. At our kitchen hospital, we use a lot of fresh produce. Many places we see that they buy the mayonnaise, for example. We make our own mayonnaise by just mixing eggs and oil and some mustard and other stuff. That way you can also have a mayonnaise that is flavored however you want it, and you can have it organic because it's always very expensive, nearly always. You can always, of course, find some very cheap and maybe not so tasty products that will be cheaper for you than if you made it from scratch. But if you want good taste also, and we want that, and of course then the patients will eat more if it tastes good, then it would be more expensive if you buy a good quality pre-made mayonnaise than making your own. We had a small guided tour in our kitchen for some participants at the big conference that we had earlier, like the CleanMed. Yes, thank you, Susan. And people were very, very surprised that we actually also made our own jam. And this is of course the bought one, but we make just to show you that we also make our own jam. Yes, and that's very nice, and then you can have any flavor you would like to, and then you can have more organic products. Of course, when you buy these fresh vegetables, then they have a lot of peels on, and you need to take that off. You can do it by hand, but then it will take a long time. So we have this nice vegetable peeling machine where you just pour in your carrots or your potatoes or whatever you have, and then yeah, you can have they're good to use. I just looked at the prices of the pre-peeled non-organic potatoes that we can buy, and that's approximately €2 per kilo, whereas 1 kilo of raw organic potatoes is about €1 per kilo. So there's a gap of €1 per kilo that you could put into buying this vegetable peeling machine. Of course, when I say we buy this, we have 80% organic food within the budget, then we have a budget for new tools. So of course they cost some money to buy, but then you also get this good organic food. Sometimes you can think about whether you actually need to peel the vegetables. You don't always need to do that. There's a lot of good nutrients in the peel as well. So, but we peel many vegetables. One thing where we also found a lot of money to buy some good organic products was to replace some more expensive products with some good but cheaper and organic alternatives. One example is we used white wine in sauces, and now we actually use local organic apple juice, which is a bit sour in the flavor, so it can substitute the white wine. We used olive oil before, and now we use this again, local organic cold pressed canola oil. Of course, it's not the same taste, olive oil and canola oil, but it's another taste, and it's actually the taste of the local oil that we, in Denmark, maybe in the 80s, a lot of Italian food came to Denmark, and everybody had to eat lasagna and spaghetti all the time, and also use a lot of olive oil, and we forgot about our own good old canola oil that we can grow in our own fields. And then of course, tenderloin, just one expensive alternative example, compared to some of the more cheaper meat cuts that you also have to spend more time this slow cooking to get it tender, but it is possible. We don't buy everything organic with the meat, but a lot of it, and it is more expensive. But with one of the meat cuts, there was no difference because we actually used a quite expensive meat cut before, but it was non-organic. Now we use another kind of meat cut. I can't tell you where it is on the pig, whether it was the arm or so. But our butchers, they know it, and they say it's still good, even though it's not the same kind of meat cut. Yes. Of course, in Denmark we have very prone, how you say, we have 4 seasons. If you go further down south, then of course you don't feel the seasons as much. But in Denmark we cannot grow tomatoes in December, so that's why we don't serve that many tomatoes. We still have at our canteen. It's difficult to talk people into not eating tomatoes and cucumber every month, all the time of the year. But it's a slow process, and I hope that someday then we won't serve that many tomatoes in the canteen. But for the patients, we try to make it more seasonal, the food. So of course, lots of cabbage and lots of roots now. And then in the summertime, have the more lighter vegetables. And yeah, they are good price if you serve food by the season. And of course, that's also one of the main goals, to have a good taste when it's fresh, compared to something that was harvested a long time ago. Yeah. In our kitchen we have our own baker. This is not, sorry, our own baker. He's handsome. That's our baker is also a cat. Never mind. And then we also have our own butcher. It gives you a better quality. It's cheaper and good quality food. It stimulates the appetite. Some kind of cakes can be really, really expensive when you buy them, when you don't cook them yourself or bake them yourself. And then you can also just, like I said before, earlier with the mayonnaise, for example, you have the possibility to flavor your food and to come up with using some of the leftovers of, for example, with the bread, and bake that into a cake, and you can use the ends of the ham or whatever to integrate into the other recipes for the food. Yeah, and then it's also really, really expensive, to, at least for us, to buy this pre-made salami and other types of cold cuts. So it's good for us to have our own butchers. Yes, using more lentils is also good. It's also good for the environment not to use that much meat, and have some proteins from the lentils and beans. Just one more example, we use organic local pearl barley, which is about €2 per kilo, while organic rice is about €4 per kilo. And rice, we cannot grow it in Denmark, so we can get local food and organic food for a lower price. So that's very nice for us. Of course, food waste, Eileen also talked a lot about. Good talk about that. Money in the bank, and you can spend that for buying organic products. Of course, there can be a lot of different perceptions of what food waste is. Still, in our kitchen, we throw out these green leaves from the cauliflower, and I don't like it. And yeah, they can actually be eaten, but some think that that is just like a leaf that you should throw out. yeah, you can see we don't have so much time left. So, but of course, food that goes bad is still food waste, even though it's rotten. Many people think that it doesn't count as food anymore because it's rotten. It's some other category, but hey, it's still, as Eileen said, you still have staff to cook the food and to buy the food, so it's a lot of money that goes out there. And then it's always nice to have a talk about the expiration date, that you should not always be so afraid of the date if you can try and use your senses to see if it's still good. But yes. And then just a quick note about a way that we also had to find money was to use the good old lean. We used to have two different kinds of yogurt. One was high in protein but low in fat, and one was high in fat and okay amount of protein. And now we found this organic yogurt, which is high in protein and high in fat. So because we wanted to buy organic food, it forced us to rethink the way that we do stuff. If we didn't need to do that, we could just still use these two, which was fine. But actually, you have the leftovers of two bottles. How do you say? 1 liter of the yogurt. You cannot empty this one completely. So if you have two that's not empty completely versus just having one that you can not empty completely, then you have less food wasted. And then also look at your menu to see, do you actually need to be able to serve cornflakes, for example? And yeah, I just found this on the website. It's not ours. Sorry, James Page at University Hospital. Jam and marmalade, you need to have both. So that's what we also done. Yeah, and then of course, food is not nutrition until it's eaten, as Eileen also mentioned. At some places they actually serve too low-fat food because they haven't actually looked at the kind of food. They haven't updated the recipes or really looked at it. Or maybe you serve too much meat. So yeah, always look at this and also look at this nice food environment. They look very happy and they also eat more because they sit together maybe and have a good chat. Yeah, in Denmark we at our hospital we spend a lot of money on this syrup for squash. And then it's energy for the patient, but maybe it's not the best energy, and maybe they don't feel so hungry because they just ate the sugar water. So that's a project that we're going to look at the next after New Year. When you want to have more organic food, don't just get rid of everything just to be more lean. You also have to be able to provide some of these high energy snacks for the patients, and also look at who gets to eat them. Me and Sissa just had a quick tour around some of the wards, and yeah, we just see that a lot of food goes into the mouth of the nurses and so. And yeah, that's just not what our budget is for, or it is, but we don't want the budget to be for that. Yes. Yeah. Finally, if you want to have more organic food, then make a strategy. How will you do it, and who should be in charge? It takes time, so prioritize it and be patient. And then the last one. Maybe you need to educate your staff more. Maybe they haven't been using a knife for a long time because they just use the scissors to open the bags of powder soup, however it's made. Yeah. So Thank you. This is some of the happy animals that we support. Yeah, and this is some of the not so happy chickens that we supported before and still are. Yeah, we don't buy everything organic. Yep, good. That's it. Done.
Okay, thank you, Susie and Nina, for introducing the snack chart concept. Is really interesting, and presenting us how to reinvest in more fresh, local, seasonal, and organic products. I hope you all have took note to start restructuring your kitchen if needed. Now, I'm going to present some of the work that we have been doing here in Healthcare Without Harm Europe this year in order to prevent and reduce food waste in the healthcare sector. As you may know, the Europe and its member states are committed to meeting the Sustainable Development Goals adopted in September 2015, including the target 12.3 to halve per capita food waste at the retail and consumer level by 2013, and reduce food losses along the food production and supply chain. To support this achievement, the communication on circular economy calls on the Commission to establish a platform dedicated to food waste prevention. The European Platform on Food Losses and Food Waste, in which Healthcare Without Harm Europe was invited to participate, aims to support all actors in defining measures needed to prevent food waste, including in the food service, clarifying European legislation on waste, food and feed, and encourage food donation, improve the use and understanding the date marking along the food chain, sharing best practice, and evaluating progress made over time. Considering this agenda, Healthcare Without Harm Europe has conducted during this year 2016 some interviews with European hospitals and healthcare systems about their strategies to prevent and reduce food waste. These interviews have been reflected in this brochure that is available online. These interviews have include 7 hospitals from 4 European countries, but also some regional programs and national initiatives as the one that Eileen has presented. These examples, as we have seen, can serve as a role model and inspire others to give the problem of food waste the recognition it deserves in the healthcare sector. Some of the results that we have obtained from these interviews has been that reducing the high wastage rate at healthcare is not only a priority, but also an opportunity to invest in better and healthy meals, reduce complications and increase speed recovery, fight against climate change, and generate social and economic benefits, and also change the old model of doing things as the circular economy proposed. By adopting these preventive and resource efficiency approaches, the healthcare sector expects to raise awareness around smart purchasing, storage, and preparation of food, optimizing their ordering systems, establishing protected meal times, offering different portion size, and improving coordination, education, and communication both internally and externally. In this regard, we have made also some recommendations that European hospitals can start implement, as for example, establish a dialogue with local food suppliers and incorporate environmentally sustainable criteria in their procurement process. Improve communication between the kitchen and the wards, but also among the patients. Establish a simplified and flexible food ordering procedure. Carry out satisfaction surveys Train and inform kitchen and ward staff about the different stages of food waste management, but also on prior phases. Use, for example, transparent waste bins to raise awareness among the staff, visitors, and patients about how much food is wasted and what type of food is more discarded. Focus on prevention and explore some alternatives to redistribute food for surplus food, and organize focus or group works for tasting different culinary innovations, consistencies, or presentations. Sorry. In this process, we have learned a lot of things, but we also believe there is still some challenges ahead. For example, in the procurement process, we have to try to maximize opportunities for sustainability, and for that we have to consider the best outset and clarify requirements to include them in contracts, both for second and third suppliers. Also, make sure you have board support, clinical engagement, and a good patient representation in the team. It's really important to provide quality input and feedback and have a multiple level approach. This includes look for expertise in other similar public institutions, organizations, and academia. Train and raise awareness among your staff, and also visitors and patients can change the mindset in the hospital. We all know that changing habits is not easy to do, but if we succeed to slowly change this mindset in hospitals, we can achieve great things. Also, look for solutions, innovative technologies to forecast your demand, to reduce the cost and wastage, and also stop and reflect throughout the project stages to make sure you are delivering the project. Because how to transform good practices into a standard practice is not really easy, but it's something it has to be done. And to finalize, also I want to present the Europe food plates that we have done that also include some commitment of the institution to prevent and decrease food waste and explore those alternatives at the different healthcare facilities. This pledge is available online in our website, so please feel free to take a look at it. And also just to announce that we will publish soon our food report. It also includes some perspective on the food waste management in the healthcare sector, but also we are trying to look at the holistic picture, so just be updated. And now we are going to address some of the questions we have been receiving, but please feel free to send us more. Just to let you know that for those who have joined later this webinar, that this session is being recorded and will be available like in a week. But in any case, yeah, this will be available. And now, Eileen, we have received a question for you, referring to, well, asked by Andy Jones. Have decreased portion size had any impact on nutritional intake, or are the portion size simply not correct?
Yeah, thanks for the question. Yeah, it would be the latter. It was the portion sizes were incorrect. I noticed there that Nina mentioned the same in their presentation, that sometimes you might get things like meat portions that were larger than required. So the improvements that the hospitals have been making here in Ireland would always be done in conjunction with the dietitians and nutritionists, and to see that they are getting the correct portions of various nutrients for their meals. So yeah, it was a case of people not appreciating the correct size, say, of a portion, and also where a hospital might buy pre-portioned, say like meat and so on, chicken portions, to try and work with their suppliers to get the correct portions coming in.
Okay, thank you, Eileen. Now, Cece and Nina, we have a lot of questions for you, that we are going to start by this one from Samantha Puntos. How did the kitchen staff have time to prepare all these things like their own jam and mayo?
Yeah, well, I guess we have more staff. Do we? Yeah, we have more staff to cook the food. That's what we have done. We've put the money from buying expensive finished products or semi-finished products, and then put it into to have some more labor.
It ended up being much cheaper to make it ourselves than to buy these huge bowls of jam which most of it was thrown away. And then we served smaller portions to the wards, so they have fresh up every day or every second day.
Good, thank you, Nina. We have also other questions for both of you. Like, for example, how gain senior organizational engagement, and what about local suppliers and producers?
Well, we have a boss who is very fond of organic food, and so it has very much also been because of him that he's really been pushing through to the what we call a senior engagement, or the higher up bosses. We have many bosses at this hospital and directors. So yeah, a personal organic flame, I guess. And then with the local suppliers, then in Denmark it's very popular, getting more popular with the organic food. So our suppliers have been more willing or open to have also these local organic products on the shelves, so that we can order them from the web shops. So that's been very nice. And sometimes again we also have to be patient, as I also mentioned. Maybe they don't have the specific organic product yet, but over time hopefully they will have it. So thank you.
Yes, thanks to you. Also, there is quite questions about the main challenges that you have had to implement the snack chart. So if you can explain more about that.
Yes. It's me, Cece. The main challenge for the snack card was to make sure that the staff that runs with the snack card, they know how to be around the wards. In the beginning, it was kitchen staff, and we had a few complaints. They don't know how to make sure that patients with dysphagia don't get the wrong food. They need to make sure that to talk to the nurses, understand what the nurses, the special like medical language. So that's been the main challenge, to find the right person to do it. Sometimes we're struggling about we're giving them some fresh food, and you can say that's not with not high nutritional value, but the patient really appreciates the fresh food. So it's always a talk about what's the most important, the patient being happy, or the nutritional value satisfied. Yeah. Thank you.
Okay, thank you. Yeah, participants also want to know if there has been any studies conducted by hospitals about food waste on the plate. Maybe Eileen, you want to try to answer this, or you, Cisa and Nina?
Yeah, in terms of food on the plate, yeah, when we were doing our food waste surveys, we would try and quantify how much was remaining on the plates, and I think that that is where there is good scope for some hospitals to reduce food waste. For other hospitals, it may be beforehand the food remaining inside in the kitchenettes, and so that's kind of the aim of our surveys, was to find out where the main areas that food is arising and the reasons why, and then if it's plate waste, then at that stage, then the hospital could look and see what are the reasons for that. And we mentioned them earlier, and also both Nina and Sissy mentioned them too. About looking at trying to get the right quantities in terms of individual portions of the different foods.
Mm-hmm. Yes, thank you, Eileen. Cisa and Nina, you want to take this as well? About if you have made any studies in your hospital about food waste on the plate?
Not really. We actually had a student who came out and made her, I guess it was her bachelor project or something like that. We tried to evaluate at two different wards. Oh, can you hear me? Sorry. Two different wards, the plate waste, but right now, sorry, I cannot. Actually, there was not that much of plate waste. But that's also about the question about your staff who serves the meal, and do they put the appropriate amount of food on the plate, like just add a little bit of food and then tell the patients that they can always come back later. But of course, if you don't have time for patients to be able to come back later because you have such a small time frame, then yeah, I don't know, maybe you can think about that. But yeah, I don't have more to say about that. Thank you.
Okay. Yes, thanks to you. Also, we have another question from Andy Jones. Thank you very much for participating. I know he said, like, it's known that it's very hard to compare, that each hospital people present what is their patients per day food cost for food, but you usually exclude labor in this cost. Can you explain more how do you calculate this food waste in terms of economic cost? Eileen?
Yeah, thanks, Paula. Yeah, we haven't put a cost on labour and cooking. So when we look at our food waste costs, we are looking at the purchase cost only, and we haven't assigned the cost of the cooking and labour. And that's why that was an interesting question both to Cecilia and Nina, and it was an interesting answer that preparing things from scratch has worked out to be not to be more expensive for them. I thought that was an interesting answer. So from our point of view, we are looking purely at purchase costs of food.
What do you consider in your cost, Cisa and Nina, when you calculate the food waste?
Good question.
Well, we do have different measures. We measure from like figures saying we have this and this when we got this amount up to the wards and how much we got with us back. We also measure the things coming back from the wards.
What do you consider in the cost?
No, what do you consider in the cost?
Yes,
Mm.
a food waste evaluation.
Oh, okay. Don't know.
Sorry.
Sorry.
I got the question wrong. I guess we just say times like €4 per kilo, and we don't. Yeah, no, sorry, don't really include labor, or maybe we do. Sorry. Yeah, but the time times the amount of food, the waste with about approximately €4, which is what the food costs in on average. Yeah, thank you.
Okay, good. Yeah, I think evaluating the cost in food waste is also really important to start comparing between different countries, and yeah, there is something in this thing that also maybe the platform can suggest, not only in terms of weight but also in terms of cost, so we can start comparing and benchmarking uh, among similar institutions. One last question for you, Cecilia and Nina, will be what will what have been the most difficult barriers in reducing food waste in your hospital?
Oh, sorry. Hello. There are many barriers, and it all comes to what kind of Paula, can you unmute you?
Yeah,
Can you?
sorry. What have been the most difficult barriers in reducing food waste in your hospital?
It has been well in the kitchen. Paula, no, Paula, sorry, Paula, just if you could mute yourself because I can hear myself. So.
Yeah, maybe you can focus maybe in the ward instead of the kitchen.
Yeah, well, in the ward, then it can be a question of. Sorry, there is a lot of noise on the line. Paula, can you mute yourself?
Yeah, sorry.
Thank you. Kind of easier. Can you think? Yeah. Well, with the staff, then on the wards, it's they like to eat the food also. So maybe they're not always so interested in having the amount of food that comes up to the ward reduced, because then there's no free lunch. And yeah, but so that's one of the questions, and then of course also that they don't always have time to actually ask the patient, what do you want? Maybe the patient, they cannot come out to the buffet and see how the food looks, and then there's no picture of the food, or they don't have the food presented, and so then it can be difficult if you don't have any appetite and you don't actually know what's been served, and the nurse maybe say there's meat and with some vegetable, and they don't say like more about how it was prepared or what kind of meat, or that it's seasonal and local and all these nice words that you can put to food that will enhance the appetite. Then that could be an issue of food waste, and you waste more food if the patient are not if they're not talked into to eat this food. Yeah. Thank you.
Yeah, that's why we were saying like training your staff is really important in that sense, to communicate with the patients and visitors, and I know you also do some training. So yeah, thank you very much for sharing your insights. One last question we are going to address is from Ceylan Guno. Sorry if I mispronounce it. Maybe Eileen, you can answer this question. It's about if you have found some estimates in the percentage or in the ratios for cooked food, glass bottles, milk, and use cartoons in the whole amount of food waste. I think this is refer more if maybe they make some kind of sorting, and yeah, if you have some data on that.
Can you just repeat the different types of food again you were saying, Paula? Milk and...
Yeah, like cooked food, glass bottles, milk, and use cartons, and maybe the different materials.
Yeah, in hospitals here in Ireland, they are obliged by law to segregate food waste, and in most cases people are getting that taken away. You saw the brown bins, the pictures of the brown bins, and mostly going to either composting or anaerobic digestion off-site. So they are obliged to keep things like, say, bottles and cartons and so on out as much as possible. Now, we always would see some little bit of contamination, maybe like wrappers on some bread or crackers or things like that, but for the most part people are good at keeping them segregated. In terms of the different types of food, we have done analysis of that in our studies, where we would try and break it down into the different meals, and also breaking it down into food that's cooked versus you know, things like that are, you know, peelings or things with no value. So about 70% of the food in the bins we found on average was food that was cooked, food that had value, food that was meant to be eaten but wasn't. So the remaining 30% would be the things, you know, things like, as well, things like, you know, bones or scraps and things like that that had no value and couldn't be eaten. Milk, I think, is a relatively small portion, but sometimes it's hard to quantify it because it might not always end up in the brown bin normally. So. And it has been a problem for some hospitals, say particularly places like maternity hospitals with, say, milk formula, and how to handle it when you've got set bottle sizes and the milk being discarded afterwards. So we have some on our website. We do have some fact sheets on food waste, and it does try and give some bit of a feel for how it breaks down into the different types. And if people had, you know, more specific questions, it would be no problem to get in touch with me, and I'll try and show them what we've found, you know, typically among different hospitals. Thanks, Paula.
Yes, thanks to you, Eileen. So please, everyone, take a look at the great work they are doing from the Green Healthcare Program in Ireland. The facts are really good and really well explained. Just to finalize this webinar, make sure you complete the survey at the end. Please, any feedback will be helpful for future ones, because we are going to have future ones. And also sign for our newsletter and take a look at our website for more updates. And any other questions you may have, like, please write to us. We will be happy to attend and answer your questions. So thank you very much, Eileen, Cise, Nina, for your great presentations and participation in this webinar. And thank you to all the attendees as well. I hope to see you in future ones. Have a nice evening.